Welcome back to Navigating the Hearing World. We're here at Wolfpack Hearing Aids in Fayetteville, Arkansas, and it's hot and noisy out here. And we're going to talk to Dustin Richards, who runs Wolfpack. He's a certified audiologist in the state of Arkansas. So full disclosure before we begin, he is my audiologist and he's been kind enough to also be our sponsor for these videos.
Hey Gary.
Hey Dustin.
How are you?
Good.
Glad you're here.
Thanks for having us.
Absolutely.
This is Dustin Richards, and he's the owner and audiologist for Wolfpack Hearing. Can you tell us how you got interested in being an audiologist?
Sure. Well, I was on about my third major undergrad. It's getting about time to declare. Took a sign language course, had a great time with it, got some exposure. Around the same time, went up to visit my grandfather in Milwaukee, had stage 3 lung cancer, had some hearing problems. I was able to visit with an audiologist there. Mm-hmm. Seemed like a great field and have not regretted it since.
So besides your grandfather, you didn't have any hearing issues in your family at all?
My mother's had hearing loss as long as I can remember, so certainly no stranger to that.
Oh, okay. So that makes sense. Okay, so let's proceed, and we'll talk to our audience about what to do next, what services you offer, and how you can help them.
Sounds great. Come on back. Okay. All right. Come on in, Gary.
Thanks. So, Dustin, can you describe to me a typical first patient? Absolutely. I understand you do what you call a case history, and since I've been doing this for so long, I'm no longer a new patient. What would be a typical process when someone comes in?
Yeah, two things I'm looking at with that case history process. All right, number one, I want to identify the hearing problem, through the eyes of the patient or a companion if they're there. That's a different thing than the hearing loss. We want to see which environments they really want to hear, and not everybody wants to hear their spouse better, for example. But definitely ties into treatment if we go that route. So identify those areas where they're having the most trouble, and also want to get into the medical and rule out medical red flags that we may need to refer out to a physician for. Okay. Obviously, I don't diagnose anything beyond hearing loss, but part of my training is to recognize those red flags. So if a patient has tinnitus or vertigo, I need to know about that. And if the answer is yes to something like that, I'm going to delve a little deeper, make sure it's not just one side, or your ear is ringing, it's not beating with your heart, or something like that. So definitely a very important part of it leading into the whole appointment.
So when people come in for their first appointment, are they usually referred, or is it just somebody saying, finally, I just need to get my hearing checked?
I suppose the latter. All right, we see quite a few referrals, and that varies. So if a kid doesn't pass his school screening, they'll be kicked over to us for that full evaluation. Mm-hmm. Okay. And whereas our physician refers, a little bit different deal, but usually they're here because they're ready to identify some sort of hearing problem.
Okay. Yeah. So I had hearing speech therapy and lip reading in grade school, but it wasn't until I was, I was in probably 3rd, 4th grade. So
not always the case. That's impressive.
Yeah. Mm-hmm. So now that you've gotten some information from them, what's the next thing? You look into their ears and...
Yeah, we're going to look in your ears, make sure I can see both eardrums. We want them to be unobstructed, normal appearance and color. The vast majority of the time where we get hung up with wax impaction is probably half my day. But if I see signs of possible fluid, again, I don't diagnose that, but I'm going to maybe move to a tympanogram, run a pressure test where I can gauge if that eardrum is able to move. Fluid, for example, that eardrum doesn't really move. You see a flat line on that test called a type B. at that point I'm going to go ahead and make that referral. There's no point in proceeding with the test. Whereas a physician refers post-ear infection treatment, regardless, I'm going to do that test. Just depends on what the case is.
So you're not actually going to get a good, accurate hearing test if there's some obstruction or if there's fluid or whatever. So at that point it's cut off.
Exactly, or maybe it will show a conductive hearing loss, not necessarily a permanent one. Well, we could have just addressed that first. So again, depends, but yes. So in the simplest terms, we hear with our ears, we understand what we hear with our brains. With that test, we try to separate those two. So looking at the tone test first, can you hear or can you not? We have the right ear in red, left ear in blue. Now the graphs are laid out like the keys on a piano. From the left side of each graph, think lower frequencies, low pitch tones, bass tones, same thing. So we go low pitch, moving to high pitch, low to high frequency. I mark the circles and X's at the softest level that you're able to pick up each one. Further down you go on the graph, the worse your hearing is. All right. So you'll do this on paper, but right here, 20 decibels, that's where we draw our line. Anything below that line, by definition, hearing loss. All right. So with this first test, we're using the earphones. That sound has to go all the way down the pathway, right?
So that's like the equivalent of 20/20 vision then. That would be your kind of average, normal.
Exactly. It's a reference line. It doesn't do much to describe a hearing handicap, but that's our reference for something like this. We call that test air conduction. To fast forward to bone conduction, that's where we use a headband. It's going to be placed right here on the mastoid. It's going to go straight to the inner ear, bypassing the outer and middle. This is how we tell what type of hearing loss you have. Okay. So these little brackets here, that's where we mark. Now, Gary, your audiogram is a little unique in the sense that we can't turn up that headband test so loud. So these are actually no responses. All right. But if you look over here, these are true responses. You see the little bracket is pretty close to the circles and X's. That indicates there's no difference whether you go straight to inner ear or you follow that whole pathway. That means your type of hearing loss is permanent, sensory neural. It's coming from the inner ear. If you had an ear infection today, you'd see a pretty noticeable gap between the bracket and the circles and X's. Okay. The most common type I see by far, that line, you'll see the low frequencies actually close to the normal range. And almost go down like that. All right. When noise induced, you might see it notch back up. The point here, most people have a high frequency loss. So you'll go into those common complaints like, I can hear you talking. I can't understand what's being said because I'm missing those consonant sounds. Vowels carry more energy. Same thing with background noise. A shape like that, Gary, that's not just clarity, that's a problem. It's also a host of things. Volume, being able to localize sound. A whole different beast right there.
Okay, so that's one point I really wanted to emphasize, because now we have the over-the-counter aids that are coming soon, and most of that, from my understanding, is going to be volume, right? And so people aren't really taking into account clarity and noise reduction and all that. So this isn't, what you're doing is not just adjusting volume. So what I have here as far as my loss goes, to compensate, and we'll look at that later, is when you program the aids, you have to program not just to increase what my loss was in volume, but to compensate to get clarity, right?
Yeah. And this is a starting point, if you will. All right, we're going to work off that. I'm also tying this to everything we talked about in the case history, okay? You mentioned this specific problem. This reflects that problem, kind of as a confirmation. But yes, this serves as a starting point. And a host of other things on top of that. With you, we ran a loudness tolerance test right here, that very bottom line, where we turn up the tones and you tell me to stop. Now, highly subjective test, I get that. But the take home here is, what's loud to you is loud to me too. And that poses a challenge. When I'm fitting those hearing aids, I have a very narrow dynamic range to work with. And that's my job in a nutshell, help people hear, help restore clarity best we can, but keep it comfortable.
Right.
All right, Gary, come on this way.
Okay.
And once you step up the ramp, come on in and have a seat. All right. All right, so from this point, I'm going to describe to the patient what we're going to do. Basically put those earphones in, and I'm going to be able to talk to him from out there, guide him through the test. We're going to go through those tones and the speech test.
Okay.
And,
all right. So I've done this many times, so I know what to expect. But you had mentioned that some people feel a little bit anxious about turning their back to you.
Right.
So what do you do in that case?
In that case, it's fine to look at me. In fact, a lot of my colleagues do it that way. Behavioral tests like this, you know how it is. I mean, sometimes you think you hear a tone, but you're not sure. So we try to reduce as much context as possible. Sure. I don't want to blink a certain way, for example. So, you know, claustrophobia can be an issue. In that case, I'll have him face me, tell him, hey, pause at any point, walk out of the booth if you need to, and, you know, whatever the patient needs. So this is where I'm running the tone test, trying to find the softest sound that a patient is able to hear, looking for 2 out of 4 responses for each frequency. Yeah, with a lot of patients, I'll run what's called the quick sentence, a speech and noise test. If we like how they did on speech discrimination, to say the word dog test in quiet, I want to go ahead and gauge how they're able to do it with background noise. So they're listening to another recording, this time in both ears, right? And that voice is reading sentences to the patient, 6 total. And the patient repeats each sentence back to me. Now, with each sentence, we're going to introduce more and more background noise, make it more difficult. And from this test, we are able to surmise how well, or I should say what deficiency the patient does have hearing in noise. Also gives us a very good idea, realistic expectations with hearing aids.
So in other words, when you reach a level of introducing background noise to the point where the person can no longer repeat back the sentence, that's when you know that's...
So we score 5 words out of each sentence. And we take that and we calculate what we call your SNR loss. That means signal to noise ratio. Again, loosely approximating how much louder does the stuff you want to hear have to be relative to the background noise. All right, so general rule of thumb, the patient will score anywhere from 7 to 15 dB. We call that a moderate SNR loss. And beyond that, we're going to refer to that as severe.
Okay.
And usually that reflects the case history pretty well.
Oh, okay. Excellent. So, so now that you've evaluated their hearing, and it looks like they need a hearing aid, what is the next step?
Yeah, so at that point I make my recommendation, okay? Now, obviously there's a lot to choose from as far as treatment goes, a lot of hearing aids. So I'm going to take the results, pair that up with the case history, the discussion we've had, try to make that recommendation.
And this is all in this first appointment?
Usually, yes,
okay.
Absolutely. All right. So for the typical patient, usually we're going to start them with about a 2-month trial, okay? We know that hearing is subjective, and the main take-home. Right. And I try to drive that point home. Also, the acclimatization process. Remember some of that. Give them expectations of what they're going to get into, and also lay out pros and cons of each style. Now, most patients are pretty good with the style I recommend. Some, you get those where they really don't want them visible, perfectly fine. We go over the pros and cons of that stuff. And again, those are going to be entirely dependent on what we're seeing from the results and the case history. So you may have a patient that after you've recommended an aid and give them a rough cost estimate, they may say, let me think about it. Yeah. And some may say, let's move on to the next step, right? So do you, if they say, let's move to the next step, do you, if they need a mold, like I do you actually cast the mold? Yes. At this point? Absolutely.
Okay.
Make impressions that day.
Okay.
So if we are proceeding to that next step, it's because the patient agrees they have a hearing problem. Okay, now this varies among my colleagues, but generally I'll tell them, yes, you're a candidate for hearing aids on paper. Okay, but again, is this affecting your quality of life? Right? And the reason that's my main criteria is because you know how important consistent usage with hearing aids are.
Right.
If you don't wear them consistently, they're useless. There's no point in doing it.
Right.
They go in the drawer. So that's what I tell them. And to be fair, some aren't ready to take that step. I'm going to give them information to take home. A lot of them like to do self-research. That's perfectly fine. All right.
Good.
So to circle back around, let's say you're ready. If I have an audiogram like yours, there's no question the style I want to go with a power behind the ear BTE, and I want to use that custom mold. Okay.
Right.
Whereas the typical patient I told you about, they have normal low frequencies. I'll go with that wire fit behind the ear and a heavily vented rubber dome so we can let some of those lows bleed out. We don't need to hear highway and AC better. Those are just general examples, okay? But I'm laying that out for them.
So then the only one that you would have to cast a mold for is for power aids.
Yes, I mean, or if they, there's some anatomical factor going to that, or a patient is a lifelong user, they started with molds as a child, we're not going to deviate from what they prefer, what they like.
I see. Okay.
So there can be some variances there.
Okay.
And also, on the technology level, right, we're kind of basing that on how they performed on speech testing as well as their day-to-day listening needs. If I have a patient with a very sedentary lifestyle, we're talking one-on-one small group. There's no sense in going beyond an entry-level technology, for example. Whereas if I have a patient that's working on, let's say, for an office building, open floor plan, 100 coworkers, no cubicles, they have dead regions, poor speech and noise test, yeah, probably going to talk about top-of-the-line hearing aids. So.
Okay. So when you said entry level, now most people think entry level as being low cost, low quality. That's not the case necessarily.
No, it has nothing to do with longevity, durability. Okay. More so the performance in background noise. That is the simplest way to put that.
Okay.
All right.
Okay.
And things like Bluetooth, direct-to-phone pairing, rechargeability, that's not really a bell and whistle. Most entry-level hearing aids have those things. Perhaps there's a better term for that. But yeah, that's a good question.
Okay. All right. So then you have to, essentially the next step would be for you to order the aids, for them to schedule the next appointment to come in and fit it. And then you have a treatment plan, right? So what can you describe that? Once they've come in, you've done the fitting, they're ready to go home now and let their brains adapt to this new concept of hearing. What would be the treatment?
Yeah, absolutely. Personally, I mean, we put a lot of importance on follow-up, so I like to see them at least 4 more follow-ups within those first 2 months. Okay.
First 2 months?
Exactly. So, and that can vary based on progress, but after they walk out the door, they're wearing their hearing aids. I'm going to see them back in about 3 to 4 weeks. From that point on, they've started to acclimate, like you said. Maybe they have more of an intuitive sense of what we're doing. This now becomes patient-driven. I'm relying entirely on their feedback at this point. Okay. So they come in with complaints. I have to make sense of those complaints, make those necessary adjustments, adjust fit issues, and then recap. We get through that initial follow-up stage. At that point, I want them coming back quarterly, every 3 months for clean-in checks. All right, very important to do that above all else, and that's where you can really make your hearing aids last. There's no reason that can't happen. And then I want to test them once a year after we've established that baseline. That's how it all works. Adjustments, we have them call as requested. All right. Like a lot of places, we're bundled clinic. I mean, those adjustments and all that stuff is factored into the cost. I know some places you'd have to pay for those office visits, and that's where the hearing aids might cost a little less. Just tough to do that on our end financially.
Right. Okay. So once they made the initial investment, the follow-ups and cleanings and all that are free, essentially.
Exactly. Now, most of the hearing aids we're going to fit, probably 6 different brands I've fit this year, non-proprietary. So that way, if a patient moves or they're snowbirds, any reputable audiologist should be able to work with that brand, or at least have the capability, the software to do it. Okay. That's my preference. Again, this is strictly personal opinion. In the 9 years I've been doing this, I don't think there's one brand that's particularly just stood head and shoulders above the rest. They each do different things well. pros and cons. You try to match that up with each patient. And I think that's important.
So that's a good point, because I wanted to talk about that, the fact that not all hearing aids are the same. Just like a car, the different brands have different qualities and different features, all that. But the features aren't as important as the comfort you have with the hearing aids. So in other words, I wear the brand that I wear, I've worn almost all my life, right? Now I've tried other brands, and the sound quality is such that it's not bad sound quality, but it's different than what I'm used to hearing and what I think of as normal. Yes. So if I try these other aids and then they have, I think you mentioned this, the sound like they're tinny, or you're inside a hollow log or something like that. And there's only so much you can do to adjust that, right? I mean, so I want people to realize that if you try on an aid and it's not what you think it should be, don't just accept it. Come back in, make, that twice, the early follow-ups. Right. At that point, say, this doesn't sound right. Don't just, because I know I've had experiences with people older people that are just losing their hearing. They come back. I had a boss who actually threw his hearing aid across the room while I was in there and said, "I've had enough of this." And I went, "Okay, look, you just had this thing for about a week or two. Give it a chance. Go see your audiologist, do something, but don't just give it up, because you have to communicate with us," right? So I just want people to understand that there's a big difference between just getting volume and just having an aid. Doesn't mean that has to be the one that you end up with, right? Yeah. So you have a return policy. We didn't talk about that. Can you?
Yeah, I mean, a general rule of thumb, as long as I can get the hearing aids back to the manufacturer within 60 to 90 days, I'm not on the hook. Okay. All right, but there should always be a return window, always a trial. What you just said, if there was anything to remember from this video, that's it. That should be the take-all right there. You must make sure that it's correct, and if it's not, you try something else. In our case, we've had those instances where I recommend hearing aids and I don't like our progress after a couple months, particularly if somebody's worn them before. Mm-hmm. And we're going to switch to something else, no question. Okay. And Gary, you are an excellent example of this. You mentioned you've worn the same brand most of your life. We tried a sister company with you. Yeah. Very, very similar technology, and it didn't jive, okay? So, you take two different hearing aids, you set those gain curves the exact same way, you'll perceive it differently. You get into things like attack release times, compression speeds, all that stuff matters. So definitely remember that point you just made. Yeah,
that's what I really wanted to get that across to people, because I can't tell you how many times I've had to tell people that don't just accept it. It's like if you went to a car dealer and they said, "Here's the car you should buy." You don't do that. You take a recommendation, right, and then you try it, and then if it's not the car you want, you get a different one. I mean, same thing with hearing aids. So
I agree, 100%. It should be no different.
Okay. All right. So then. And I know for me, as far as your follow-ups and all that, you've recommended having your aids cleaned once a year or 6 months? 3. That's okay. So now I don't do that. But
yeah, that may be excessive to some. And, a lot of patients are great about cleaning their own. Okay. But, we get them back there. We're going to gut those hearing aids, take them apart, run them through drying chamber. Maybe stuff we don't necessarily want every patient doing. But I think that's crucial. And, drive your car for a few years without changing your oil and see what happens. It's no different. Right. Very important.
Okay. And the last point I wanted to make was, you mentioned drying, opening up and drying them. Well, now, for me, I have a little dehumidifier that you take out part of it and put it in the microwave to, you can keep using this over and over again. And every night I put my hearing aids in that humidifier. It sits on my nightstand. And, if you're out in the humidity or, working outside, I always put those first thing in that dryer. And that, I'm sure that extended the life of my aids considerably. So
nowadays, self-care is great. Nowadays, even with nano coating on hearing aids and things like that, moisture resistance has improved. Why would you not do that? I mean, that makes sense to me. Yeah. And now nowadays some of the dryers are UV bulbs instead of having to microwave those bricks and things like that. So, if you're in a place where you can't come quarterly, or maybe the clinic you went to, that's not the follow-up schedule, or for whatever reason, I think it's great to add something like that. Yeah. No doubt.
Okay. All right. Well, I think we're good. Dustin, thank you. Thanks for your time. I appreciate it.
Thanks for having me.
Thanks to everyone for watching our video, and look for us on Fayetteville Public TV.